Okay, now the approach of malabsorption, you start with a good history. Okay, the most important points to take in history are the age and onset of diarrhea. When did the diarrhea start first? Okay, the relation of diarrhea onset, okay, or severity to dietary changes. Were there any dietary changes when the diarrhea happens? Okay, if if it is secretory or osmotic diarrhea, actually this is not a point, not from history, you have to take it into account. Okay, the characteristics of a stool. Okay, is it hard, is it soft? I'm going to pass on that. Okay, associated symptoms of the malabsorption. I'm sorry. Now let's get back and talk about every point of them into details. Why do we have interest in age and onset of diarrhea? Okay, why is it important to us? Because diarrhea in neonates, okay, has different causes from diarrhea in infants, which has also different causes from toddler diarrhea. Okay, so diarrhea in neonates causes are almost always congenital causes. Okay, we have maltase or amylase deficiency. Tell me, what maltase and amylase do? They have an important role in the carbohydrate absorption, as I told you in the previous video. Okay, maybe glucose and galactose malabsorption. Okay, so we may have a normal amylase and a normal maltase that forms a normal glucose and galactose and fructose, but we may have glucose and galactose malabsorption congenital syndrome, for example. Okay, so what also we may have villus atrophy, and the causes of villus atrophy are much. Okay, but of them we have enterocolitis, for example, we have giardia infection. They all can happen in neonates. Also lactase deficiency. I told you that in carbohydrate absorption digestion we have maltase, we have lactase, and we have sucrase that break down the maltose, the lactose, the sucrose in order. Okay, lactase will break down the lactose into glucose and galactose. If we have lactase deficiency, so the glucose and galactose will not be absorbed, so we have malabsorption. If we have maltase deficiency, like in neonates, okay, congenital maltase deficiency, we will have malabsorption. If we have amylase deficiency, we will have malabsorption, because the amylase break down the polymers of or the polysaccharides, the starch, into simple or disaccharides. Okay, we may have also congenital chloride or sodium diarrhea. Okay, cystic fibrosis, very very important. It's somehow pancreatic insufficiency disease. I'm going to talk about it in separate video about cystic fibrosis. Okay, but now take into account in congenital or the diarrhea in neonates, the cystic fibrosis is very important. Also there in infants, cystic fibrosis is still very important. Okay, bile acid malabsorption. So these are mostly the causes of diarrhea in neonates. Okay, what about diarrhea in infants? Diarrhea in infants has some causes in common with diarrhea in neonates, like for example cystic fibrosis. Okay, congenital sucrase or amylase deficiency may manifest at infants. Okay, but what is important about infants, or what is specific about diarrhea in infants, that in infants we start to give the baby a different type of foods. Okay, so the baby may transformed into formula administration instead of breastfeeding. So we may have what we call cow's milk protein allergy, and also I'm going to talk about this in other separate video. Okay, we may start to feed the baby, okay, and this may be associated with an important cause of diarrhea in infants, very important, the great celiac disease. And also I'm going to talk about it in separate video, but this is a kind of allergy to the ways they raise, okay, some kinds of food. Okay, so these are the specific things about diarrhea in infants. Okay, again, cow's milk allergy, celiac disease, cystic fibrosis, congenital sucrase or amylase deficiency, also maybe bacterial overgrowth may cause it. Toddler diarrhea, we have sometimes idiopathic toddlers diarrhea, nothing specific. Okay, in late childhood, okay, the late childhood diarrhea may be due to celiac disease. So here we start to get away from the congenital causes like maltase, sucrase, lactase deficiency, like cystic fibrosis and other things. We start somehow to get away from it. Okay, we have causes like celiac disease, like inflammatory bowel disease, Crohn, ulcerative colitis. Okay, lactase deficiency is still possible here. So if you notice that in neonates we have the lactase deficiency as a cause, okay, or maltase deficiency. In infants the sucrase deficiency starts to be more important. In late childhood still lactase deficiency may happen. So this is the important things about the age and onset of diarrhea, when did it start. Okay, so you have to ask about this. Relation of diarrhea onset or severity to dietary changes. Did you use some new type of food? Okay, did you change the milk that the child take? Okay, why? Because we have cow's milk allergy, as I told you. Okay, it's allergy to different formulas of milk. Okay, allergy to some proteins in the milk. We have celiac disease, allergy to food, and the celiac disease start to be complained as 6 months when you start to administer some types of food like bread and other things to the baby. Okay, so this second equation. What is the third equation? Is it secretory or osmotic diarrhea? Actually, you have to ask yourself this question. Okay, you can make the baby nil per oral for 24 to 48 hours. Okay, if the diarrhea resolves, then we have osmotic diarrhea. This diarrhea is due to food. Okay, something about osmolarity of the intestinal tract makes this diarrhea. Okay, so if you stop the food administration, it will resolve. If preserve the food if you stop the food administration for 24 to 48 hours and you still have diarrhea, so it is secretory diarrhea. It's not about food, it's about other things. Okay, and you can know if it is secretory or osmotic diarrhea by counting what we or calculating what is called stool osmotic gap. How to calculate stool osmotic gap? By measure the osmolarity. Okay, and we have the measured osmolarity now and the calculated osmolarity. Okay, so okay, to make it more clear, we have two values: the measured osmolarity and the calculated osmolarity. Okay, the calculated osmolarity is by equation, which is 2 multiplied by stool sodium plus stool potassium. So 2 by stool sodium plus potassium. Okay, so this is the calculated osmolality. The measured osmolality is by lab examination. You measure the osmolality of stool. If you take the calculated osmolality from the measured osmolality, if it is more than 50 milliosmol, then it is osmotic diarrhea. Okay, more than 50 milliosmol, it is osmotic diarrhea. Okay, so this is how to differentiate between secretory and osmotic diarrhea. If it resolves with food or not. If it is resolved with food, is osmotic. With food cessation, is osmotic diarrhea because it's related to food administration. If it preserved even when you stop food for 24 to 48 hours, it's secretory diarrhea. Now the third point in history is the characteristics of stool. If you have a blood streaks in a stool, that indicates you have an inflammatory process, you have an infection. Okay, either inflammation or infection may lead to blood streaks in the food. Inflammation like what? Like cow's milk and allergy, for example. Okay, if you have watery sour smell, diarrhea is mostly carbohydrate diarrhea. Okay, or carbohydrate malabsorption diarrhea. If you have bulky, pale, pasty, offensive cheese smell, it is steatorrhea, a fat diarrhea. Bulky, pale, greasy, offensive, like cheese smelly. Okay, so it's fat diarrhea. This is how to take history. You have to ask about the age and the onset to know the differential diagnosis with the diarrhea of neonate, infants, diarrhea of toddlers or late childhood. Every age group have, or each age group has its own underlying causes of diarrhea. Okay, you have to know the relation of diarrhea to the onset to the dietary changes. Okay, you have to know if it is secretory or osmotic diarrhea, the characteristics of stool, and the associated symptoms of diarrhea. Do you have any skin lesion? Do you have fever, fail of thrive? You have to ask about these. Now let's move to the second thing in the practical approach of diarrhea, the physical examination. After history, you have to take a physical examination. The very important points about the physical examination of the growth parameters: you have to know the weight of the patient, to put it on the chart of weight. Okay, you have to know or to look for the signs of nutrients deficiency, like the paleness, the presence of edema, like in protein diarrhea. Okay, muscle tone and volume of the muscles. You have to look for skin, for bones, muscle tone, for any fractures. For example, in rickets disease, you have vitamin D deficiency. For skin lesions, for example, in zinc diarrhea, if you have losing of zinc, you have some significant skin lesion. You have to look at hair and etc. Okay, so signs of nutrient deficiency and vitamins, of course. Now, investigation of diarrhea, you have to start with blood work. Okay, if you have to check albumin out, because albumin may be loose. You have to see CBC. Why? To look for anemia due to diarrhea. If you have microcytic RBCs, maybe iron deficiency anemia. Macrocytic, it's due to vitamin B12 deficiency, folate or folate malabsorption. Okay, if you have lymphopenia, lymphocytes decrease, maybe lymphangiectasia. If you have neutropenia, maybe due to Schwarzman syndrome. Okay, I'm going to talk about this in details. Okay, so you have to do CBC. You have to know the albumin. Okay, PT is important because some cases of diarrhea or malabsorption, we have vitamin K deficiency. So PT, if it is prolonged, then we have vitamin K malabsorption. okay, bone profile for rickets, okay. So TTG, why? Because you may have celiac. I told you celiac is very important cause of diarrhea and malabsorption. I'm very sorry. Okay, zinc levels, because acrodermatitis enteropathica, enteropathica lesion is associated with zinc, okay, zinc deficiency. So you have to look for zinc levels, blood, CBC, bone, PT for vitamin K, and zinc level. These are the general measures that you have to investigate for in malabsorption, but you have specific things to take into consideration if you have, for example, carbohydrate malabsorption or fat malabsorption or protein malabsorption. Each one of them has its own measures, okay. In carbohydrate malabsorption, you have to check stool reducing substrates. In the stool you may see sucrose, fructose, glucose, okay. The levels of these things may indicate the presence of malabsorption of carbohydrate, okay. Acidic stool, in carbohydrate malabsorption you have acidic stool, so you have to check stool pH. Breathe hydrogen test. Hydrogen levels in the breathing may be increased in multiple cases, okay. One of the most important cases is the malabsorption of carbohydrate because of presence of lactose, sucrose, fructose in the stool will increase the hydrogen of bacterial, okay, in the hydrogen in the breathing, okay. Bacterial infection also is the cause of hydrogen in breathing, okay. So you have to check breathing hydrogen test, and if you suspect carbohydrate malabsorption, stool reducing substrate, that will show you lactose, sucrose, and glucose, okay. So these are the specific tests to do in carbohydrate malabsorption. Fat malabsorption, okay, you have to quantitatively determine the presence of fat in a stool. How much fat do you have in a stool, okay, and this is done by sudden red stain, okay. And to confirm that, you do what we call 72 hours fecal fat. So they collect the stool for 72 hours, okay, and they check out the fat in the feces. How much fat do we have, okay. Normally in a premature babies, they absorb about 65 to 75% of fat, so it's normal to find about 25% of fat in a stool, okay. In full term children, we have 90% absorption, so no more than 10% fat is acceptable in this stool. In older children, about 95% fat absorption happens, okay. So in the 72 hours fecal fat, you have to find out no more than 25% at most in the premature babies, or 5% in the old children, okay. No more than 5% fat in the stool. If you find more than this, so you have to suspect fat malabsorption, okay. If you confirm the presence of fat malabsorption, so you have to further investigate for the underlying causes that may lead to fat, okay, malabsorption. Like what? Like cystic fibrosis, very very important, the most common congenital cause of malabsorption, okay. For cystic fibrosis, due to a sweat chloride test, fecal elastase, serum bile acid, okay. This is for cystic fibrosis. Lipid profile, very important. The vitamins, okay. In fat malabsorption, we have decrease in vitamins like vitamin D, vitamin A, and vitamin E, vitamin K. You have to check them all. Vitamin A, for example, you check it by serum carotene, okay. PT for vitamin K deficiency, and vitamin D, vitamin E. Okay, so remember this. If you confirm the presence of malabsorption fat, for example, you have to check out the cystic fibrosis by sweat chloride test, fecal elastase, serum bile salt, okay, lipid profile. All of them should be done. Okay, serum. So most of fat malabsorption is with pancreatic insufficiency. Okay, so cystic fibrosis, I told you, is about pancreatic insufficiency. To confirm the presence of pancreatic insufficiency, you can do serum trypsinogen. Okay, serum trypsinogen will indicate the residual of pancreatic function, so you have to do this. So this is all about the fat malabsorption, the specific thing about fat malabsorption. To investigate protein malabsorption, if you suspect protein malabsorption, you can detect the serum albumin. You know that serum is a protein. Okay, so you check the serum albumin, and the most important thing is to check the stool alpha 1 trypsin or alpha 1 antitrypsin deficiency. Okay, so if you have a stool alpha 1 antitrypsin deficiency, is a very important marker for protein losing enteropathy. So remember, in a protein deficiency or in protein malabsorption, you have to check alpha 1 antitrypsin protein. If you find it out in the stool, this is a very important marker for losing a protein losing enteropathy. Okay, in addition to the special test to do in carbohydrate, fat, and protein. Okay, remember them all: the acid stool and the carbohydrate, the stool reducing substances. Okay, it makes sense to investigate these things in each type of malabsorption. Okay, and in addition to the general investigations, we do the CBC, the PT, the TTG for celiac disease, the zinc levels. Okay, we do the barium swallow test. Why? To check out if we have any anatomical defects like a short gut, like malrotation. By the way, malrotation is the most common anomaly to cause the malnutrition or malabsorption. Okay, Hirschsprung disease. Okay, so you have to do barium swallow test to see if you have one of or more of these anomalies. Okay, short gut, malrotation, Hirschsprung disease. Also, intestinal biopsy is very important. Intestinal biopsy, by the way, it's the most confirmative test for the celiac disease. Okay, so intestinal biopsy, you can see the presence of villus structure, okay, atrophy. And actually villus atrophy is non-specific, maybe with cow milk protein allergy, maybe with post-enteritis case. Okay, if, for example, giardia or malnutrition, all of them may be associated with villus atrophy. Okay, Crohn milk protein, because there is an inflammation and villus atrophy. Okay, post-enteritis, giardia infection. Giardia infection are also diagnosed by aspiration. Okay, aspiration from the intestine. Okay, intestinal biopsy may show you villus atrophy. It also may show you lymphangiectasia. Okay, I'm going to talk about lymphangiectasia in subsequent video. Inflammatory cells or eosinophils. Okay, in celiac disease we have what we call a March classification. You may see inflammatory cells in 1 degree of March classification. Okay, I think it's 2nd degree. Okay, you can see inflammatory cells. Eosinophils is an indicator of presence of allergy. Okay, electron microscopy also can be done. So these are the investigations to be done in malabsorption. Don't forget them. Okay, I advise you to subdivide them into the general tests to be done. Okay, like CBC, PT for vitamin K, TTG for celiac, zinc levels. Okay, bone profile for rickets, and specific tests for carbohydrate, fat, or protein loss. Okay, I told you them all. And the imaging studies like barium swallow to see if there is any anatomical dysfunction that led to the malabsorption, like malrotation very important. Okay, intestinal biopsy to see if we have any intestinal villus atrophy, lymphangiectasia, inflammatory cells, and so on. Okay, so this is all about the general concept of malabsorption, definition, the physiology of absorption, the signs and symptoms of malabsorption, the practical approach to malabsorption, the history, physical examination, and investigations. In the subsequent videos, I'm going to get into details of the diseases that may lead to malabsorption. I'm going to talk about celiac. Okay, I'm going to talk about cystic fibrosis, okay, in separate video. Okay, I'm going to talk about cow's milk allergy and about lymphangiectasia and other things. Thank you very much for watching. See you in the next video.